I think I'm visible and audible to all of you. Okay, let me restart my YouTube. Otherwise, I'll not be able to see your comments. Okay, now I can see that. All right. So, boys and girls, yes. So, the idea of this INICET Predictor Ophthalmology session is to give you questions which are very conceptual, which are in sync with your INICET upcoming exam, right? So what I have done is I have split up the questions into multiple topics. So we'll starting with the orbit, then lens, uvea, glaucoma, retina, neuro-ophthalmology, squint, conjunctiva, cornea. So I have handpicked a few questions for all of you which I feel are kind of tricky. Yes, and most of you students tend to do mistakes. Yes, so ideally there should be 10 questions which are discussed, but I am going to discuss a little more questions. The basic idea is to touch the important topics which will help you in understanding the core concept. And as usual, as you always know, I always show the real patient videos. So in this 1 hour, I won't be able to show all of the associated real patient videos. But yes, I have handpicked a few which will help you conceptualize the topics. Hi Akanksha, hi Kavita, hi Utkarsh, hi Kesani. All right. So that is going to be the agenda. And yes, you can be part of my Telegram group where I keep on discussing MCQs. There are quizzes which are going on. I keep on sharing the links. And you can also follow me on Instagram where I have started my Rule of 2 series. So almost every other day I give 2 clues of etiology, of pathogenesis, of treatment, and you need to tell me the diagnosis, right? And I have recently started my YouTube channel as well. You can be a part of YouTube channel. I have added some videos, but I plan to add some more clinical conceptual videos. If you want me to, add a particular topic video, just let me know, drop me a message and I shall do that, है ना? And any queries you have, you can always WhatsApp me on this number. Yes, 9814111330. You can always WhatsApp me and I'll be there for you. I'll try to answer your queries ASAP. And of course, we have our damsdelhi official YouTube channel on which you are seeing me. So you can follow this, subscribe to this. You can also follow us on Telegram, damsdelhi official. You can also follow us on Instagram. The handle is damsdelhi. All right. Now with this, can we start with it? Yes. तो हम start करने जा रहे हैं. So the first topic which I told you I am going to discuss is that of the orbit. Yes. So first topic is that of orbit. This is your previous year question. Intermittent proptosis is seen in. Boys, what is intermittent proptosis? Intermittent proptosis is the proptosis which is present at one point of time and which is not present at other point of time. Intermittent. Sometimes there is proptosis, sometimes there is no proptosis, right? Now what happens is there are 4 options. Out of these 4 options, the answer, can you give me the answer? Yes. Now the answer I'm going to tell you in the end, but first let's discuss carotid cavernous fistula, fracture of roof of orbit and sphenoid dysplasia. In these diseases, what happens is that there is a connection between middle cranial cavity and the orbit, as a result of which you know that through the cavernous sinus there is passage of internal carotid artery. Yes, and when there is carotid artery ruptured, so that there is a communication between internal carotid artery and the around lying cavernous sinus. So the pulsations of the heart, pulsations will be transmitted to the cavernous sinus. Yes, and with dhak, dhak or lub, 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 with systolic pulsations of the heart, the pulsations will be transmitted to the cavernous sinus and then to the orbit, so that the eye will move anteriorly, posteriorly, anteriorly, posteriorly, anteriorly, posteriorly. You will call this type of proptosis as pulsatile proptosis. Yes, pulsatile proptosis. The same goes with that of the roof of the orbit, and the same goes with that of the sphenoid dysplasia, because the roof of the orbit, and which of course the roof of the orbit is formed by frontal bone and lesser wing of sphenoid, and if there is sphenoid dysplasia, the same carotid pulsations are transmitted to the orbit, leading to pulsatile proptosis. Yes, but what is orbital varix, my dear friends? Orbital varix is when the patient lies in prone position, so due to collection of the blood posterior to the eyeball is pushed forward. Yes, and there is proptosis, but the patient lies supine, so due to gravity all the blood, it gets drained due to gravity, and the eyeball goes back into the orbit. So that is what you call as intermittent proptosis, and hence is the answer here. Yes, and as I always say, that if you will see the patient, you will never forget it. Now I am going to show you the video of a patient of pulsatile proptosis. Can you appreciate the patient with pulsatile proptosis? Dhak 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 dhak. This patient had a history of trauma leading to corticocavernous fistula. Is it understandable? Can you appreciate pulsatile proptosis? Yes. All right. So this is our patient with pulsatile proptosis. I hope you have understood, hai na? So the basic idea is to connect the dots, right? Okay. Yes, very good, Dr. Sahil. Sphenoid dysplasia, if I take it a little further, it is seen in neurofibromatosis type 1, and neurofibromatosis type 1 there is another important tumor which is associated, and that tumor is optic nerve glioma. It is optic nerve glioma. Is it understandable? All right, let's move over to the second question. I hope it is understandable. So the basic idea is the first three are the examples of pulsatile proptosis. The last, which is D option, is an example of orbital varix. Yes. Okay. Now coming over to the question which was asked as such in your INICET November 2023 exam. Yes. The following instrument is used for. What is this instrument? Can you appreciate this instrument? The same image was asked. Yes. From the chapter of orbit. And this instrument is what? Yes. Can you answer me? This instrument is exophthalmometer, है ना? And if exophthalmometer, this is exophthalmometer. If this exophthalmometer is used in adults, you use Hertel's exophthalmometer, Hertel's. But if you use in child, the name of the exophthalmometer is Ludi's exophthalmometer. Yes. Now, what is exophthalmometer? Exophthalmometer is an instrument which assesses the quantitative proptosis. See, there are two methods of assessment of proptosis. One is quantitative, second is qualitative. Qualitative is you tell whether the patient has proptosis or the patient does not have proptosis. Yes. Quantitative is when you actually measure the proptosis. Now, can you tell me what is the distance from the lateral orbital rim to the center of the cornea, on which basis you will say that the patient is having proptosis? If it is more than equal to 20 millimeter, that means distance of lateral orbital rim to the center of cornea, from the lateral orbital rim to the center of cornea. It is scale like a thing. You keep it at the lateral orbital rim, and here it is central cornea. This distance you measure, and if it is more than equal to 20 millimeter, you say that the, yes, 20 or 20, more than equal to 20 or 21. Yes, some books mention 21, some books mention 20. It's one and the same thing. So you will never get an option 20 and 21 both. So it can be 20, it can be 21. You can mark either. If 21 is not in the option, go for 20. If it is 17, 18, 19, 20, go for 20. If it is 18, 19, 20, 21, go for 21. Yes, okay. All right. So this is how you measure proptosis. So this is quantitative method, है ना? Now you will say, sir, name is exophthalmometer, but it assesses the proptosis. So what is difference between proptosis and exophthalmometer? So there is one term which is proptosis, which is protrusion of the eyeball. There is another term which is exophthalmos, that is also protrusion of the eyeball. Then what is the difference? There is no difference. It's just that if there is proptosis in thyroid eye disease, you call it as exophthalmos. I always give one example. So in Punjab, so there is a person named Ram. You know, na, in Punjab, most of the, people dream of going and getting shifted to Canada. Yes. And when this Ram gets shifted to Canada, he changes his name from Ram to Rambo. So Ram and Rambo is one and the same thing. But when Ram is in Punjab, he is Ram. When Ram is in Canada, he is Rambo. So exophthalmos is proptosis in thyroid eye disease. Okay, I hope it is clear. Yes. All right. Now I told you this is quantitative method. Now can you guys tell me what is the qualitative method of assessment of proptosis? Can you tell me? Yes. So there are two methods. One is you stand at the back of the patient. You ask the patient to look towards the ceiling. And after standing at the back of the patient, you look out for relative position of the eyeball. That is your which test? That is your, very good, Dr. Akanksha. So proud of you. Ziegler test. Provided you are standing at the back. Yes. But if you are standing in the front, what is this test? That is a worm's eye view. That is worm's eye view. Yes. But as I always say, if you will see it being done, you will always and always remember. I am going to show you the worm's eye test. Check this out. So what I am doing is, I am asking the patient to look where? I am asking the patient to look towards the ceiling. Now, what did I do? I am sitting in front of the patient, and I am asking the patient to look upwards, and I will look out for the relative position of the eyeball. Yes. So this is your worm's eye view. Is it understandable? Okay. I hope you have understood. Now, I am going to give you 4 important MCQs. Trust me, one of this MCQ has the highest probability to be asked in your INICET exam because it has been asked previously quite a good number of times. 1. Most common unilateral cause of proptosis in children. Can anyone tell me? Yes. Make this session very, very interactive. I don't want you to just keep sitting and waiting for me to tell you the answers. No, this is your live session. Yes, I want all of you to interact with me. Can you tell me what is the answer? So the answer is orbital cellulitis. This is your question number 1. Most common bilateral cause of proptosis in children. Very good, Dr. Kisani. Yes. Very good, humble doctor. Very good, Akanksha. Can you tell me the most common bilateral cause? It is neuroblastoma. Yes, neuroblastoma. Okay. Now, can you tell me the most common unilateral cause of proptosis in adults? Yes, it is thyroid eye disease. Thyroid eye disease. Can you tell the most common cause of bilateral proptosis in adults? boys and girls, it is again thyroid eye disease. So I gave you 4 MCQs: orbital cellulitis, neuroblastoma, thyroid eye disease, and again thyroid eye disease for adults, unilateral and bilateral. So unilateral cause was asked in your INICET May 2024 session. Wonderful. I am so proud of you. So proud of you. All right. Now moving over to the next question. Okay. So yes, this is also your previous year question. So I thought to discuss this because it was a little controversial because of the image which was there. So a 35-year-old male presented with proptosis, fever, decreased vision, and history of recurrent sinusitis. There was discharge from the nose and NCCT was done. So this is your NCCT. Now can you see that this is air? Can you appreciate the air? But boys and girls, here there is no air. There is a fluid level, inflammation. So that tells you this is which sinus? This is your ethmoid sinus. Yes, this is ethmoid sinus. So what is there? So there is ethmoid sinusitis. But you know, ethmoid sinusitis can lead to orbital cellulitis. What is orbital cellulitis? Orbital cellulitis is when there is inflammation of the entire orbit. But here, don't get confused. Here, you can see that there is a periosteal elevation. Can you see that there is periosteal elevation? But here it is clear. Had there been involvement of this area in entity, had there been involvement of this entire area, you would call it as orbital cellulitis. But here you can see periosteum is elevated and there is again the fluid level which is pushing the medial rectus towards outside. So boys and girls, this is not orbital cellulitis. This is actually your subperiosteal abscess. Yes, I am so proud of you. Dr. Rituja is the first one to answer this. And Dr. Suba, Akanksha, Jat Boy, Gurdeep, very good. Too good, man. Too good. So happy for all of you. Okay. All right. Now, next is your lens topic. Now, which type of cataract is this? This is your FMGE question which was asked in your June 2024 session. So, what is this? Can you tell me what is this? So, this is your which cataract? This is a typical cataract which is your rosette cataract. Can you appreciate the rose-like shape? Can you appreciate the rose-like shape? And this rosette cataract is seen in which trauma? It can be seen in blunt trauma. I always give one example that there was a Valentine's Day. And the boy went to the girl to propose her with a rose in his hand. But you know, in today's world, it is very common. The boys would connect to it kind of dearly. I like you, but as a friend. Hai na? So the boy thought that the girl also loved him, but it was not like what he thought. It was, I like you, but as a friend. But the girl got so angry when the boy proposed to her that she slapped boy so hard that the rose that he was having in his hand got stuck into his eyes. So slapping is which form of trauma? It is blunt trauma. The rose getting stuck into the eye. Which cataract? Rosette cataract. Yes, I hope it is understandable. So rosette cataract is seen in blunt trauma, and typically in a blunt trauma the cataract is your posterior cortical. But if I talk about penetrating trauma means a foreign body has entered into the eye, piercing cornea. So it is going to hit where? It is going to strike where? It is going to strike at the anterior lens. Yes, and anterior lens will have anterior cortex or posterior cortex. It will have anterior cortex. So in penetrating trauma there will be anterior cortical cataract. Is it understandable? Yes. Can we move on to the next question? All right. Now next topic I have for you is your uvea. Okay, which of the following is true about Behçet's disease? So Behçet's disease, as you all know, has the ability to cause anterior uveitis. Yes. What are the etiological factors associated with anterior uveitis? My dear Carthaginian, it is not anterior subcapsular dear, it is anterior cortical, penetrating trauma, anterior cortical. Yes. Okay. Now, if I talk about anterior uveitis, can you tell me the most common etiological factor of anterior uveitis? It is idiopathic. It has got no reason. Idiopathic. Yes. And what are the other etiological factors? Remember it as PAIR. P for psoriasis, A for ankylosing spondylitis, I for inflammatory bowel disease. You are already aware of inflammatory bowel disease, which is Crohn's disease and ulcerative colitis. And R for no, don't say rheumatic heart disease. It is actually Retter's disease. Yes, it is Retter's disease. Don't say rheumatic heart disease. In fact, it is juvenile rheumatoid arthritis. Juvenile rheumatoid arthritis, which is associated with your anterior uveitis, not rheumatic heart disease, not rheumatoid arthritis. It is actually JRA. है ना? Now, Behçet's disease is associated with one human leukocyte antigen, but this pair which I just told you is actually HLA-B27. But if I talk about Behçet's disease, it is not HLA-B27, as many of you have rightly answered. It is HLA-B51. So that is not true. But in Behçet's disease, there is aphthous ulcer. The condition will be bilateral and steroids are given, and there will be hypopyon. Typically, there will be presence of hypopyon. Aphthous ulceration is there. Genital ulcers are also there. This is a clinical presentation of your Behçet's disease. And you know, if we are talking of anterior uveitis, which is autoimmune, there is no infection, so which will be the drug which you will prefer? It will be steroid. So the answer to this question is A, because Behçet's is HLA-B51. Yes, I hope all of you have understood. Okay, now coming on to the next topic of glaucoma. Guys, this is a kind of controversial topic, so please pay attention. I am going to clear all of your doubts with respect to the treatment of glaucoma. Yes, but first let's do the question, then I'll be clearing your doubts. All right. A 28-year-old female visits IOPD with sudden painful loss of vision. Number one. So you need to highlight the points. It is very important. That is the best way to reach to a final answer. And I have seen students, what they will do, they will simply search on for the answer in the 4 options. I always say, what I always did was always reach to the answer by the method of exclusion. Keep excluding the incorrect options. You are increasing your chances of getting the right option picked. Yes. Okay. Now, this sudden painful loss of vision is associated with nausea and vomiting. On examination, cornea is edematous and conjunctival congestion is there. But there is also presence of halos. Yes. So it goes in favor of, can you tell me? It goes in favor of acute attack of angle closure glaucoma. The other name of acute attack, see, ध्यान से सुनना है, अपनी आंखें और कान ध्यान से देखो और सुनो. Yes, acute attack of angle closure glaucoma is also known as, boys and girls, acute congestive glaucoma. Acute congestive glaucoma. Yes. All right. Now, this is an acute attack, so you need to decrease the IOP ASAP, as soon as possible. How you are going to do it? You are going to do it by giving IV mannitol, because it starts to act in as less as 20 minutes. So you will give IV mannitol. I am talking of medical management, and along with it, you can also give pilocarpine. Yes, pilocarpine, it will constrict the pupil, so there are chances it will open the block. This is one thing. I am talking of acute attack. Okay, once you have given mannitol, what will be your next step after giving mannitol? You will go on for a procedure which is your laser iridotomy. Laser iridotomy. What is laser iridotomy? With a laser, you will try to make hole in the iris, so that there is more aqueous humor coming from posterior chamber to anterior chamber, such that the posterior chamber will get decompressed and the iris will fall back, leading to widening of the iridocorneal angle. My dear humble doctor, primary treatment will be mannitol only, and along with mannitol you will give pilocarpine. If both are in the options, you will pick mannitol plus pilocarpine. If that is not in the option, go for mannitol. If that is not in the option, go for pilocarpine. Why I am telling you? NEET PG 2024 question, there was one option in which there was mannitol and pilocarpine, so that will be a better pick. Yes, I hope you have understood. So laser iridotomy, is it clear? Have you understood? Okay, but now if I want to do laser iridotomy, I have to focus on the iris now. I have to focus on the iris through the clear cornea. What if that cornea is hazy? In this case, see, could you see that cornea is edematous? Cornea is edematous. So will you be able to focus on the iris through the hazy cornea? You use NDAG laser na, you will not be able to focus. If there is hazy cornea, you will not go for iridotomy, you will go for surgical iridectomy. This is one option, surgical iridectomy. If there is hazy cornea, because you need to focus on the iris. So this is another point. So this is about acute attack of angle closure glaucoma or acute congestive glaucoma. But if I talk about the drug of choice, because for any glaucoma, primary open angle glaucoma, primary angle closure glaucoma, normotensive glaucoma, so the primary treatment is always management. The drug of choice for all these three types of glaucomas is prostaglandin analogs. I am telling you about medical management, boys and girls. Prostaglandin analogs, you already know: latanoprost, bimatoprost, travoprost, tefluprost. I hope it is understandable. Yes, don't confuse primary angle closure glaucoma with that of acute attack of angle closure glaucoma. Acute attack is sudden raised IOP from 15 millimeter of mercury to 60 millimeter of mercury in just 30 minutes, boys and girls. Sirf 30 minute mein, 30, only 30 minutes. Yes, I hope you have understood. But if prostaglandin analogs is not in the option, because previously the drug of choice for primary open angle glaucoma was not prostaglandin analogs. Why? Because a 3 ml bottle of prostaglandin analogs would cost 1500 rupees. So then the drug of choice was beta blockers. So if the question comes, what will be the drug of choice in primary open angle glaucoma, you will look out for prostaglandin analog. If that is not in the option, go for beta blockers. Yes, and I told you prostaglandin analogs previously very costly. If they have asked about drug of choice or PACG and prostaglandin analog is not in the option, earlier the drug of choice was pilocarpine. I hope now you have understood. I have cleared all of your doubts. And if I may ask you, what is the surgery of choice? Because medical management is the first management, the management of choice. If the patient is not responding to medical therapy, what will be the surgery of choice? Primary open angle glaucoma, you will go on for trabeculectomy. This is the gold standard surgery. If you have ever attended my lecture, I have shown you the real patient trabeculectomy video with mitomycin 0.02%, if you could recall. Yes. Okay. Yes, I hope you have understood. And for PACG, you know, you will go for laser iridotomy. I hope it is understandable. Give me thumbs up if you have understood all the core concepts of the glaucoma treatment. Please give me thumbs up if you have understood. Yes? Okay. All right. चलिए अब हम आते हैं रेटिना की तरफ. I hope I have cleared many of your controversies, because these are the controversies which I have been receiving from past so many days, so many weeks, so many months. Yes? Okay. Now, in retina, which of the following has a familial inheritance? Retinoblastoma, you already know there is one gene, that is RB gene, which is present on chromosome 13. Each chromosome has a long arm, has a short arm, so it is present on a long arm, and there is a band on that long arm which is 14. So 13q14. For retinitis pigmentosa, you know it can be sporadic, your previous year question, or it can be hereditary. Yes? All right. And myopia, you know, myopic degeneration, remember pathological myopia, it is hereditary. Primary open angle glaucoma, of course, there is genetic predisposition which is present. So, in other words, all the options are correct. So, the best answer to pick is C, which is 1, 2, 3, and 4. All right. Okay. Which of the following will not cause punched out lesions in the retina? So punched out lesion is, it will look like the part of the retina has been punched out. So toxoplasmosis, yes or no? Yes or no? Congenital rubella, yes or no? Posterior staphyloma, choroidal coloboma. So in toxoplasmosis, there are punched out lesions, yes, because of scarring. In congenital rubella also there are punched out lesions. In choroidal coloboma is due to non-development of the tissue, again punched out lesions. So here the answer is posterior staphyloma. What is staphyloma? Can you tell me what is staphyloma? Staphyloma is weakening of the outer wall, weakening of outer coat of eye or outer wall with uveal tissue incarceration, with the uveal tissue incarcerated posteriorly. Yes, with uveal tissue incarcerated. Hello Dr. Omkar, same here. Okay, so can you tell me what is one important cause of posterior staphyloma? Can you tell me the important cause of posterior staphyloma? Yes, boys and girls, waiting for you to answer. So one important cause of posterior staphyloma is high myopia, and this posterior staphyloma is mostly present in the posterior segment. It is present in the posterior. Very good, Dr. Divyamsu. Very good, very good. So posterior staphyloma. Yes. Okay. Okay. I want to just increase the level a little bit. Congenital rubella, there was one question which was asked, and that question was, which of the following is not seen in congenital rubella? Can you tell me the features that you see in congenital rubella? Yes? Yes? Can you see? Can you tell me? So, yes, very good, Dr. Divyamsu. Salt and pepper retinopathy. What else? What else? Number one. Second is microphthalmos. What is microphthalmos? Normal axial length of the eyeball is 24 millimeter. If the axial length of the eyeball is less than equal to 21 millimeter, you call it as microphthalmos. What else? Sensory neural hearing loss. Sensory neural hearing loss. What else? Yes, very good, Dr. Subha. there is bilateral pearly white cataract. Pearly white cataract. So these are the important features because we are finding congenital rubella in one of the options. So I am just doing a little bit of touch and go so that this 1 hour video is highest yielding, even if you will watch it after some time, just a few days before sitting for INICET exam. Again, you just watch it at 1.5x, 1.75x. So you will get almost, 20 to 30% of the important information extra in this video. Okay, all right. So can you appreciate the punched out lesions? I have specifically put up a pic. So these are your punched out lesions. All right. Now next is your neuro-ophthalmology and squint part. Where is the likely lesion here? Can you tell me? So this is your parametric chart. First thing to remember is whenever you read parametric chart, you keep it in front of you and it is as if it is your own visual field. So if you are reading this chart, so this is your right side, this is your left side, and you can see that there is hemianopia on the right side. But typically along with hemianopia, can you appreciate the central part which is left? So this is your right homonymous hemianopia with macular sparing. Yes, can you appreciate with macular sparing? All right. Okay. Now, can you tell me what will be the answer to this question? Will it be left occipital lobe, or will it be right occipital lobe, left lateral geniculate body, or optic chiasma? Let's understand this question with the help of a diagram. So I am going to show you one diagram which I feel is very important to understand this conceptually. So I am going to show you. So you have to focus on this image. Check this out. Please focus on this image. Check this out. So what happens is, so let's suppose there is a right eye. If there is right eye, so you divide right eye into two parts, the right part, the temporal part, and the left part, the nasal part. Yes, the temporal fibers go into the same site, while the nasal fibers, they cross such that there is formation of the optic chiasma. So this is the nasal fiber of the left eye. This is the nasal fiber of the right eye. Have you understood? Yes. And both the temporal fibers will lie on the same site. Yes. Now, if there is transaction at the left optic tract means here, can you appreciate where there is my cursor? If there is transaction at the left optic tract, so that means left ipsilateral temporal fibers are gone, and right, which is contralateral, nasal fibers are gone. Yes, but left ipsilateral temporal fibers, they interpret the right nasal field. That means on the left eye, the temporal retina is going to interpret the left eye's nasal field, and similarly the right nasal retina interprets the right eye temporal field. So ideally the patient will not be able to look on the right side with the left eye and on the right side with the right eye if there is transaction of optic tract. Yes. Now ultimately the optic tract fibers, they pass through lateral geniculate body and they ultimately land up into the occipital lobe. Occipital lobe is one lobe. It is anatomically one lobe, but functionally it is divided into two parts. The left part of the occipital lobe receives left optic tract fibers. The right part of the occipital lobe receive right optic tract fibers. Have you understood this? Now, ideally, if there is damage to the left part of the occipital lobe, what you should get? You should get right homonymous hemianopia. But here in the image, it is not right homonymous hemianopia, boys and girls. It is right homonymous hemianopia with the macular sparing. Now you will say, sir, why there is macular sparing when all the fibers are getting damaged? my dear friends, you need to understand one important point, that the left occipital tract fibers, they are entering into left part of the occipital lobe, but the fibers which are coming from the center of the retina, macular fibers, they are not only going towards the left occipital lobe, they are going deep into the occipital lobe. What is the difference? Left occipital lobe, superficial, blood supply is posterior cerebral artery. Yes, but the core of the occipital lobe has another blood supply, which is middle cerebral artery. Now, if the patient had left occipital lobe stroke, that means which artery is damaged? Posterior cerebral artery is blocked. So ideally you will think, okay, that means the patient should have right homonymous hemianopia, but because the macular fibers are going deep into the occipital lobe where it is having additional blood supply by middle cerebral artery, so there is typical sparing of the macular fibers, so you will have macular sparing. I hope now you have understood. So I have got a doubt by Dr. Deeps, sir, why it can't be left LGB lesion? It also shows keyhole. My dear friend, there is a difference between macular sparing and keyhole visual field defect. So what is keyhole visual field defect? Keyhole visual field defect will be like this. Yes, it is like this, but macular sparing is like this. It is like this. I hope you have understood, my dear friend. Yes? Okay. And Dr. Subha, very good. So there is another concept which is congruent, or which is congruous visual field defects and non-congruous. Congruous visual field defects are the defects which are symmetrical. Congruous visual field defects are the defects which are symmetrical, and they are seen in occipital lobe, temporal lobe and parietal lobe lesions. You understand, na? If there is parietal lobe which is involved, so there will be what? Pie on the floor appearance. If there is temporal lobe, pie in the sky appearance. And these are congruous visual field defects, while non-congruous visual field defects will be optic tract, optic chiasma and so on. Yes, optic chiasma, optic tract, optic chiasma. I hope it is understandable. Yes, चलो अब हम आगे चलते हैं. What is the most likely diagnosis seen in the 9 gazes? So let's solve this query. So check this out. The left eye is elevated in adducted position, but right eye is not able to elevate in abducted position. Can you tell me which muscle causes elevation in abduction? It is superior rectus. Yes. Which muscle causes abduction? It is lateral rectus. Which muscle causes depression in abduction? It is inferior rectus. So the right eye is not able to elevate as well as not able to depress. So that means which muscles are involved? Superior rectus is involved and inferior rectus is involved. I hope you have understood. Okay. Now check this out again. So left eye is elevated in abducted position. Yes, going up, going on the side, going downwards. But what about right eye, my dear friends? Right eye is not able to adduct. That means which muscle is involved? Medial rectus is involved. Yes, is it understandable? Medial rectus is involved, and also it is not going up. Which muscle is involved? Inferior oblique is involved, but it is going down. So that means which muscles are involved? There is involvement of the superior rectus, there is involvement of the inferior rectus, there is involvement of the inferior oblique, there is involvement of the medial rectus. Can you tell me which nerve is the nerve which supplies these 4 muscles, boys and girls? So this is your, yes, this is your right third nerve palsy, because it is right eye and there is movement there is movement deficit in the right eye. So the answer is right third nerve palsy. I'm going to show you one patient. Check this out. Can you tell me which muscle is involved? Yes.
सज्जे देखो. सज्जे.
Check this out.
खब्बे. सज्जे.
Yes.
ऊपर देखो, ऊपर. नीचे देखो.
This is the real patient scenario for you. Yes.
चोट कब लगी थी? कितने समय पहले लगी थी चोट?
So the position of the eyeball is down and out, and you can also see that there is ptosis. So this is again a third cranial nerve palsy. This is your third cranial nerve palsy. I hope you have understood. Very good, Dr. Subha. Very good, very good. All right. Now let's come over to the seventh topic, which is our cornea. Yes, just 3-4 more questions left. So identify the lesion. So first and foremost is why there is blue background. Why? Because I am examining the eye in which light. So this light is cobalt blue light. Yes, cobalt blue light. What is the relevance of cobalt blue light? You take a fluorescein strip, you put it on the cornea, the fluorescein dye, wherever there is epithelial defect. See, I need to tell you, please, focus here. I need to tell you. So what happens is, if there is epithelium defect, the fluorescein dye has the tendency to enter inside the cells, provided there is epithelium defect. And this fluorescein dye will absorb blue color and it is going to emit green color. Yes, this is known as fluorescence. Now this is cobalt blue light, and since you can see that this entire area is green, it tells me that the fluorescein dye has entered in this region cells. So that means there must be epithelial defect in this region. Yes. Now let's look out for the possible answer. So cobalt green fluorescein dye, corneal opacity. No. If there is corneal opacity, why will fluorescein dye be entering into the cells? There is opacity, fibrosis. Yes. And we don't use cobalt green light. It is cobalt blue. So that cannot be the answer. Yes. Cobalt green, trypan blue, corneal degeneration. Trypan blue dye is going to stain the lens capsule. It is usually used for staining of the lens capsule. Trypan blue dye. And of course, it is not the cobalt green light. And corneal degeneration is unless there is an ulcer, it will not give way of the fluorescein dye to enter inside the cornea. Yes. Next is cobalt blue light. Yes. Lissamine green dye. You will always stain the eye with the fluorescein, and you will do the examination under cobalt blue. But if you are using lissamine green, you will examine the eye not under cobalt blue. You are examining the eye under normal light. You don't use any filter. You use normal light. And what is interstitial keratitis? My dear friend, interstitial keratitis is inflammation of the stroma without epithelial defect. If there is no epithelial defect, how the dye is going to enter inside the cells? Ultimately, there has to be some defect, na? Some, if there is some compromise of the epithelium, only then the dye will be entering inside the cells. Now coming over to C option, cobalt blue filter, yes. Fluorescein dye, yes. Corneal ulcer, yes. What is ulcer? Ulcer is epithelial defect along with inflammation. Yes. So there is epithelial defect which will allow the fluorescein dye to enter inside the cells, and you will examine the eye under cobalt blue light. So hence C is the answer. So I have explained you the entire concept of the dyes here. I hope it is clear and understandable. If you still have not understood any part of it, you can again WhatsApp me, get back to me, and I'll be happy to respond to you. Okay, now next topic is your conjunctiva. This is also your previous year question. The following is an image of the patient before and after the use of phenylephrine drops. After the use of phenylephrine drops. So what has happened? So what is, there is a blanching. Can you answer me? I am going to show you the real patient. There is blanching of conjunctiva on putting the phenylephrine drops. So I am going to show you the patient which had come to me, and you will yourself see. So you can see that there is a small nodule and inflammation on the nasal side. This is a case of episcleritis. Yes, can you see? Now what I am going to do, I am going to put a drop of phenylephrine. So pure phenylephrine was not available with me. So the most commonly used dilator in the eye OPD is tropicamide and phenylephrine combination. So I had put tropicamide and phenylephrine combination, and you will see that there is complete blanching of the conjunctiva. So I am taking the short history. I'll not be going deep into it. I just want to demonstrate. So this is the inflammation that you can see. I just want to demonstrate. Check out. So what I am doing is, this is your phenylephrine drops which I am putting. On putting the phenylephrine drops, yes, I have put the drop. Okay, now after putting the drop, so this is the right way of putting the eye drop, right? Okay, I hope you know. Okay, now after just 1 minute, 30 seconds, 1 minute, you will see what has happened. Now can you appreciate the inflammation, the congestion has gone? Yes, so this is a case of episcleritis. But as I always say, as teachers, it is also our responsibility to make your rock solid concepts. Can you tell me what is the difference between episcleritis and scleritis? Can you tell me what is the difference between? Because if the vessels are blanched, only then you will go on for marking episcleritis. If there is no blanching, you will go on for scleritis. Yes, of course, the history will be different. Scleritis is associated with pain. It is associated with autoimmune diseases like rheumatoid arthritis, Wegener's granulomatosis. That is an entire different thing. But I want you to not cram the things. I want you to conceptualize it. So there is inner layer of the eye, which is retina. Then there is choroid, and then there is sclera. Yes. And can you tell me what lies outside the sclera? Don't say conjunctiva. बहुत मार पड़ेगी. 20 दिन बाद INICET एग्जाम है. It is your Tenon's capsule. And then we have got conjunctiva. Yes. Now you'll say, sir, okay, where is episclera then? Where is sclera then? Now there are 3 layers of the sclera, my dear friends. The outermost layer is episclera. So don't think that episclera is something which lies outside the sclera. It is a part of sclera, episclera. And then the middle layer is your sclera proper, and the inner layer is known as lamina fusca. Now if there is inflammation of the episclera, you call it as episcleritis. If there is inflammation of sclera proper, you call it as scleritis. I hope you have understood. Yes, very good, Dr. Somika, very good. This is what I want from all of you. This is what I want. Too good, too good. So proud of you. So this is the concept which I wanted to give here. Okay, now identify the sign given in the pic. So this is topic 9, which will be including ocular adnexant trauma. Yes, what is this? Don't say pseudo exfoliation. It is pigment dispersion on the anterior lens capsule in the form of a ring. So which ring? This is your Washius ring. This is your Washius ring. Yes. And how will you differentiate it from KF ring? KF ring is the copper deposition. It is copper deposition where? It lies on the Descemet's membrane of cornea seen in Wilson's disease. Very good all of you. What is Fleischer's ring? Fleischer's ring is iron deposition. Where? In the epithelium of cornea seen in keratoconus. Weiss ring. What is Weiss ring? It is posterior vitreous detachment, and it is very shiny. Posterior vitreous detachment, it gets detached in the form of a ring. You call it as Weiss ring. Yes, very good Dr. Rituja, Dr. Suba, Dr. Kavita, Dr. Gurdeep, Dr. Asavri. Okay, nice name. Okay, so boys and girls, so this was very good. Dr. Somika, very good. PVD, very good. You are the first one to tell me, Dr. Somika, very good. PVD. Okay, so now let's move over to our next question. After giving you 3-4 important concepts here, identify the procedure done and the condition. Yes, okay, what is this procedure? What is this procedure? Can you identify? I know these procedures are a little tricky, so I purposefully included it because I want you to remember 3 surgeries which we done in which? In where? Which we done in entropion or ectropion? Can you tell me what is the answer here? Yes. So there are surgeries which are done in entropion. Entropion is inward rolling of the eyelid. So there are 3 surgeries. One is your Jones procedure, another is your Bix procedure, and then there is Quickert procedure. Now you need to understand, please pay attention. This is the best method to understand. And remember, Jones procedure is you simply give a cut and you tightly suture it. So if you will give a cut, you tightly suture it, the eyelid will roll outside. It is turned inside now. So entropion will be cured. Number 1. Second is Bix procedure is you simply do a wedge resection of the eyelid and you tightly suture it. So you do a wedge resection and you tightly suture it. So there will be a stretch which will be developed in the lower eyelid. So as a result, the eyelid will get back to its normal position. You call it as Bix procedure. Now there was one scientist whose name was Quickert. He stole a part of Jones and a part of Bix. Part of Jones means you give an incision, and a part of Bix means you do a wedge resection. You suture it tightly, you also suture it tightly. So this is your Quickert procedure which is done in entropion. So you know, with due respect to Quickert G, actually he did not steal it. I am just making you remember this, that he stole a part of Jones, he stole a part of Bix, and the answer will be Quickert. So the answer to this question is Quickert procedure because it consists of the horizontal incision and wedge resection. Now if we are talking of entropion, let's do a little bit of ectropion. The name of the surgeries are pretty straightforward. VY operation and next is Z plasty. So it is easy to remember. Yes, VY operation and Z plasty. Alright. So that is for ectropion. So these are few surgeries. Please don't leave such brownie points because we tend to leave such topics, and when this topic comes we lose. And I always say in my class, every single MCQ has the tendency, has the ability to shift your post result party celebration from Malaysia to Mahabaleshwar. Don't let that happen, right? Okay, now the last question, kind of, you know, on retinoscopy. Some students find retinoscopy difficult, so there is a big concept. So I am going to do only the calculation part here. In case you want to know more about retinoscopy, you can always message me your doubts. I am here to answer to your doubts. But here we'll be doing the calculation part. Okay, now retinoscopy was done from a distance of 1 meter and homatropine was used. Yes, and at x-axis the neutralization happened at plus 3.50 diopter and at y-axis plus 2.50 diopter, right? But 1 meter distance, so you will go on for correction of -1, and homatropine was used, so the correction is 0.5 -1 minus 0.5, so net and net it will be plus 1.00 because you are ultimately going to deduct minus 1.5 and plus how much, 2.00. So you will give spectacle correction with respect to this equation. Now I want to give a spectacle correction. What I can do is I can give plus 1.00 diopter sphere, because you know the sphere glasses are going to act at both x-axis and y-axis. So here this will become 0. So you have completely neutralized the y-axis. But here you require +2, but you have given sphere. So sphere is going to devote +1 to both axes, y-axis and x-axis. So you are left with plus 1.00 diopter at x-axis. So now you need to add +1 diopter sphere, +1 diopter power only at x-axis, not at y-axis, because y-axis is already neutralized because it was just +1 and you have given sphere. So you will give plus 1.00 diopter cylinder, because cylinder is going to act only in one axis, not both x-axis and y-axis. Yes, so you will give cylinder. Now there's a principle. The principle says if you want to give cylinder at x-axis, which is at 180 degree, you place the cylinder at y-axis, which means at 90 degree. I again repeat, if you want to give the cylindrical power at x-axis, you will place the cylinder at 90 degree, and vice versa. If you want to give cylinder at y-axis, you will place the cylinder at 180 degree. So it will be 90 degree placement. Yes, very good, Dr. Somika, very good. So there is another equation which we can do. I can go on for the other way. I can go on for +2 diopter sphere. If I will give +2 diopter sphere, this x-axis will be 0 because this is completely neutralized. But at y-axis, my dear friends, we require +1. But I have given +2 diopter sphere. So sphere is going to impart +2 power both at x-axis and at y-axis. But at y-axis I require +1. But through the sphere I have given extra +1 at y-axis. Now to bring from +2 to +1, I will give -1 diopter cylinder. Now this cylinder power I require at y-axis. So I am going to place this cylinder not at 90 degree as I told you just a few moments back. I am going to place it at x-axis, which is your 1. Very good, Dr. Somika. So proud of you. It will be 180 degree. Now these are the two equations. Now let's search out for the options. So they have just asked about the cylinder. So either +1 diopter cylinder at 90 degree or -1 diopter cylinder at 180 degree. So out of these, so the option is +1 diopter cylinder at 90 degree. A is the answer. I hope you have understood. So that is the concept of retinoscopy. If you want to have more clarification about retinoscopy, you can always and always WhatsApp me. Yes, and ask for it. I am going to share the voice note. Try to solve MCQs. Now in the end, I am going to give you one equation. What you are going to do, you are going to solve this equation and you are going to WhatsApp me your answer, and I'll tell you whether you are correct or incorrect. So retinoscopy was done from a distance of 1 meter and cyclopentolate was used. 1 meter cyclopentolate was used, and after doing retinoscopy, so there was +5 and +6 diopter. So this was the equation. So I need you to answer me, send your answers to this number. So Dr. Somika wants to ask something. Sir, can you please tell other corrections with respect to distance and drugs? Okay, I am going to tell you. If you are doing retinoscopy from a distance of 66 centimeter, which is 2 by 3 meter, you are going to deduct -1.5. If you are doing it from 50 centimeter, you are going to deduct -2. And if you are doing it from 1 meter, you are going to deduct -1. So this is the distance correction for you, Dr. Somika. Now, based on the cycloplegic, if you are using atropine, you are going to deduct -1. If you are using homatropine, you are going to deduct -0.50. If you are using cyclopentolate, you are going to deduct -0.75. If you are using tropicamide, you are going to deduct -0.25. Right? Yes, Dr. Rituja, atropine -1. But I want you to send me the answers. Yes, so this is the equation. You will apply the distance correction, you will apply cyclopentolate correction, and you will send me your final equation on this number, and then I will let you know whether you are correct. And if you are not correct, don't worry, I am going to correct you. Hai na? All right, so boys and girls, this was all from my side, and as always, it is always a pleasure to spend time with you. You guys are my fuel, and thank you. Hope to see you soon. You can follow me on Instagram, you can follow me on Telegram. Let's stay in touch, let's stay connected. And yes, any doubts, any queries in ophthalmology, you are most welcome. So love to all of you. I hope to see you soon. Bye bye. And INICET आप क्लियर करेंगे, अच्छा रैंक लेंगे, मिलेंगे जरूर. कोई गाइडेंस चाहिए हो, पोस्ट रिजल्ट, और डीवीटी भी हो रहा है, डीवीटी में भी मिलेंगे. वी आर कमिंग इन 6 cities this time, so I am really excited. So this is the first time we are conducting our DVT in 6 centers all across the country. Feeling very excited to meet all of you from all across the country. And yes, मिलते हैं जल्दी. Take care, bye bye and ciao.